Welcome! As the title suggests, this presentation will serve as an introduction to pharmacogenomics. If you have minimal clinical experience with genetics, or if you wish to brush up on some of the terminology we will be discussing throughout this educational series, please also consider referencing the presentation titled Genetics Terminology Basics. By the end of this educational series, we hope that you will be able to describe how genetic polymorphisms affect drug response, utilize pharmacogenomics to guide clinical decisions regarding medication therapy, interpret patient-specific pharmacogenomics testing results, and identify where you can find published guidelines and further resources regarding the topic. Regarding the utility of pharmacogenomics, the CDC states, "Pharmacogenomics is an important example of the field of precision medicine, which aims to tailor medical treatment to each person or to a group of people. Pharmacogenomics looks at how your DNA affects the way you respond to drugs." As a profession, we have come to realize that the one-size-fits-all model does not apply to medications. Differences in the way patients respond to medications may be explained, at least in part, by variable genetics. When a drug is administered to a patient, there are three main potential outcomes. One group, most often the majority of patients, experiences the expected benefit from the drug. For example, a patient administered an antihypertensive achieves anticipated blood pressure lowering. Another group of patients will not experience benefit from the exact same dose. Keeping with our same example, these patients would experience little to no blood pressure lowering effects and may require a higher dose than the benefit group to achieve similar results, or an alternate drug altogether. The third option is that patients would experience an adverse effect from the exact same dose as the benefit group, such as excessive blood pressure lowering or profound hypotension with our example drug. This group may benefit from a lower dose or an alternate medication. Understanding how our genetic makeup affects our response to medications may allow us to predict in which of these groups our patients reside, depending on the medication we choose. This will allow us to maximize drug efficacy by determining if patients may require higher doses to achieve therapeutic benefit, as well as minimize drug toxicity by avoiding medications or doses that are more likely to result in adverse effects. Utilization of pharmacogenomics may also aid in new drug development to target specific genetic markers and assist in development of more specific dosing recommendations based on patients' genetics. There are a number of ways that a genetic polymorphism may impact our body's response to medications. They may affect our capacity to absorb, distribute, metabolize, and excrete medications as determined by genetic alterations known to impact these pharmacokinetic parameters. From a pharmacodynamics standpoint, differences in genes that code for receptors and transport enzymes may also result in varied responses to medications. This will all be explained in detail in the following slides. The majority of what we currently understand about pharmacogenomics and how specific variants affect medication centers on metabolism. There are many published guidelines, which we will discuss later on in this presentation, that include dosing recommendations in the instance a patient has one of these genetic variants known to affect drug metabolism. As mentioned on the previous slide, we know that genetic variations may impact drug efficacy by altering receptors and binding sites for various medications. Here is an example of someone with a normal, or the most common genotype that codes for a drug's receptors, resulting in the normal phenotype. We would expect a patient with this phenotype to achieve therapeutic benefit from the drug. A hypothetical variant, which we will refer to as variant A, results in fewer receptors specific to this medication. In this case, we would expect a patient to have a diminished response compared to patients with the normal phenotype. Depending on the extent to which the receptors are reduced with this variant, the patient may experience minimal benefit from this medication. Alternatively, patients may present with variant B, which results in no receptors, and therefore the medication would not provide any benefit. An alternate agent would need to be considered in this case. Another possible variant, variant C, may have slight differences in its genetic code, resulting in altered receptors and ultimately preventing the medication from binding to said receptors. In this case, the outcome would mirror that of patients who have variant B, and the drug would be ineffective. In reality, there are likely many more than 3 variants that code for a drug receptor. Another way in which our genetics may play a role in our response to medications includes alterations in our genetic code related to transport proteins impacting drug uptake. We know of incidences where a genetic mutation results in decreased transporter expression and reduced drug uptake into cells. Ultimately, this can lead to extracellular accumulation of the medication. A great example of this phenomenon relates to the SLCO1B1 gene, which codes for a protein responsible for transport of simvastatin, a cholesterol-lowering statin, into the liver. Individuals with a mutation in the SLCO1B1 gene resulting in decreased transport of simvastatin into the liver to be metabolized are more likely to experience adverse effects, such as muscle pain, secondary to this drug accumulation. Perhaps the best understood way in which our genetics impact response to medications includes variations in drug breakdown. Mutations in alleles comprising the genotype of enzymes responsible for drug metabolism result in differences in the extent of drug breakdown. These mutations may result in an abnormally active enzyme, leading to increased enzymatic breakdown compared to patients with the normal phenotype. The result of this mutation will depend on whether the drug is already in its active form or if it requires metabolism to its active form in the case of prodrugs. These differences will be discussed later on in this presentation. Alternatively, a mutation in this enzyme may cause it to be less active and metabolize medications more slowly, resulting in decreased enzymatic breakdown overall. Again, the exact impact of such a mutation would depend on the nature of the drug's formulation. CYP enzymes are responsible for the metabolism of many of the medications we use in practice today and are often the subject of pharmacogenomic-based dosing guidelines. This chart does not include all CYP enzymes known to be involved in drug metabolism, but gives you an idea of those that are most common. Examples of medications with dosing recommendations based on pharmacogenomics are found in the far right column. There are a number of published guidelines referring to human leukocyte antigens and various transporter proteins, which we will delve into deeper in subsequent presentations. Depending on the combination of alleles or genotype for a drug metabolizing CYP enzyme, a patient can be classified as a poor metabolizer for that specific CYP enzyme, an intermediate metabolizer, normal metabolizer, rapid metabolizer, or ultra-rapid metabolizer. These are phenotypes. Many drugs are metabolized by several different CYP enzymes, so sometimes multiple phenotypes must be considered when making dosing decisions. These phenotypes also have different implications depending on whether the drug is an active drug or a prodrug that requires metabolism into active metabolites. Prodrugs are inactive compounds that must undergo metabolism to active metabolites in order for patients to experience pharmaceutical benefit. In these cases, metabolizer phenotypes have different implications. For example, if a patient is a poor metabolizer for a CYP enzyme responsible for metabolism of drug A, an active parent compound, we would expect them to be at a very high risk of experiencing adverse effects. If this same patient was prescribed drug B, a prodrug that required metabolism by the same CYP enzyme for which the patient is a poor metabolizer, we would expect this drug to be far less effective given it would experience minimal to no metabolism into its active form. Let's go through a couple of examples. Citalopram is an antidepressant that is primarily metabolized by CYP2C19. If a patient was classified as a CYP2C19 rapid metabolizer, you would expect that the drug would be metabolized to inactive metabolites more quickly than in a normal metabolizer. Therefore, the patient is likely to experience reduced effectiveness and may require a higher dose than normal metabolizers in order to experience similar clinical benefit. If other antidepressants had more favorable pharmacogenomic profiles for this patient, it may be better to select an alternate agent. Warfarin is an anticoagulant that is metabolized by CYP2C9 amongst a few other minor CYP enzyme pathways. If a patient was classified as a CYP2C poor metabolizer, you would expect that the drug would be metabolized to inactive metabolites more slowly than in a normal metabolizer. Given that warfarin is metabolized by a variety of pathways, CYP2C9 poor metabolizer status would not necessarily preclude us from using this medication. However, it would provide helpful information that would guide us to use a lower starting dose in order to decrease this patient's risk of bleeding. Clopidogrel is an antiplatelet agent that is metabolized into its active form by CYP2C19. If a patient was classified as a CYP2C19 poor metabolizer, you would expect that the drug would be metabolized to its active form to a much lesser extent than in a normal metabolizer. There is evidence to suggest that these patients do not derive the same clinical benefit from this medication, with guidelines suggesting these patients be prescribed an alternate antiplatelet medication. Codeine is a medication used for acute pain, but this medication is a prodrug that is primarily metabolized by CYP2D6 to morphine, which provides the majority of the pain relief patients experience from this medication. If a patient were classified as a CYP2D6 ultra-rapid metabolizer, you would expect the drug would be metabolized to morphine much more quickly than in a normal metabolizer, and you are likely to see higher plasma concentrations of morphine. Therefore, the patient is more likely to experience adverse effects and oversedation, which could even be fatal. Alternate therapies would likely need to be explored in this particular case. There are a number of different resources you can utilize to find out even more about pharmacogenomics and how it applies to your current practice. PharmGKB is a pharmacogenomics knowledge resource that encompasses clinical information, including clinical guidelines and drug labels, potentially clinically actionable gene-drug associations, and genotype-phenotype relationships. You can access this database by visiting www.pharmgkb.org. CPIC guidelines are designed to help clinicians understand how available genetic test results should be used to optimize drug therapy. A separate presentation has been created to delve further into PharmGKB and CPIC guidelines, including how to navigate the websites and how to interpret and use the guidelines in practice. Lastly, there will also be presentations that include walkthroughs of sample patient reports for both GeneSight and OneOme. These presentations, as well as links to other helpful resources, will be available on the newly built Pharmacogenomics tab of the Pharmacy Resource Center shortly. Thank you for listening to this presentation. It would also be appreciated if you could provide any feedback with regards to this educational presentation in the survey that accompanies this material. Please reach out via email if you have any questions about the material included in this presentation. mHealth Fairview is looking forward to utilizing pharmacogenomics to guide our clinical decision-making and practice. We hope you found this presentation helpful.